Hello, everybody. Welcome to our new race-approved webinar with Katie Whitford, which is about cataracts and post-op complications. So we're going to be going over what care you should be doing before the cataract surgery, what the cataract surgery is and the different options that are available for you, as well as the post-operative complications. So we're very happy to have Katie Whitford with us today. A little bit about Katie. She graduated from Ridgetown College in 2004. She passed the VTNE the same year and started working in ophthalmology at the Alta Vista Animal Hospital in 2004 as well. And she recently actually just passed the VTS exam for ophthalmology in the fall of 2020. So that's the reason why she's the one giving the webinar today. And she enjoys reading, baking in her spare times, and has two dogs, a 12-year-old English Springer Spaniel called Bo, and a 9-year-old German Shepherd Husky mix called Lily. And so I'm at Animal Health. I'm pretty sure you already know, but we do products for dry eye disease as well as for cataracts. We've been around for over 30 years, and we strive to provide medical grade, high quality products for our companion animals. There we go. So Katie, I will let you take it away.
Perfect. So just wanted to thank IMED for having me do this. It was a bit of a different project for me to do. So we're going to talk about cataracts. We're going to talk about what causes cataracts, what we need to do with a cataract, and what the possible complications can be, and kind of go through that. So what are cataracts? So cataracts are defined as an opacification of the lens. And so when that happens, we aren't able to see as well. So when the lens becomes opaque, light cannot pass through to the retina, which means that the retina cannot send the signal to the brain to process your image. So obviously that becomes detrimental to animal sight, whether it be in one or both eyes. We do see cataracts very commonly in dogs. We can see it in other species as well, but probably the most common species that we do cataract surgery in is in our canine patients. So what causes cataracts? There are a few different cataracts that we can see, and they can be caused for a lot of different reasons. So primary cataracts are when they are a primary problem, so they are independent from other diseases. Secondary cataracts are caused by something else. So we can see that from diabetes, we can see it from trauma, different ocular diseases, whereas primary cataracts tend to be more of a genetic in origin. So cataract surgery is usually a fairly well-tolerated surgery. However, there are some things that can cause it to not go as well. And that's why we need to make sure that we're doing a full ocular exam prior to deciding if the patient is a good candidate for cataract surgery or not. So some things that can interfere are KCS actually. Keratoconjunctivitis sicca does interfere with the cornea, and so you might be thinking, well, we're worrying about the lens. What does it matter if the cornea is not working properly? But if in order to do cataract surgery, we need to be able to see through into the eye, which means we need the cornea to be clear. If we have KCS already, we know that the cornea is at risk of developing some scarring, some vascularization, some pigment. So it can also cause inflammation, and we already know that we will cause inflammation during our phaco emulsification, during our cataract surgery. So we're trying to limit as much other inflammatory processes as is possible. So we need to make sure that there's, if there is KCS, it's well managed, make sure that there's no other eye conditions going on, such as uveitis, not related to the cataract, or glaucoma. So what are we doing to evaluate the patients for these things? So for KCS, obviously we need to measure the tear production that the patient has. And then we also need to check an intraocular pressure to make sure that we don't have glaucoma if we have an elevated value, or if we have significant uveitis with a low value with our tonometers. So how are we doing these things? So for KCS, there's a few different options that are available. There is the standard Schirmer tear test, and then the newer I-tear test as well. We can also evaluate the tear breakup time to see what the tear consistency is like, and then we'll use a tonometer to measure the intraocular pressure. So what defines KCS? So keratoconjunctivitis is a reduction in the ability of the tear glands to produce tears. So what this means is that the tear glands themselves are not producing the tears that are needed for the dog. And we do see this most commonly in dogs. We can see it in cats, and it's probably actually underrepresented in cats. And there's a lot of people that are working on that now. But dogs are our main focus for that. And there are certain breeds that are more prone to developing this. So this schematic shows the different layers in the tear film that we see. So there's the mucin layer, which is the innermost layer that's right against the cornea. And this is developed from the goblet cells. And this is what keeps everything kind of adhered to the cornea. We then have the aqueous layer, which is derived from the lacrimal gland. And this is what has all of the extra nutrients in it. And then the last layer is the lipid layer, which is derived from the meibomian glands. And this is what helps to protect the tear from dissolving. So why are tears so important? So tears are basically trying to keep the cornea healthy, keep the cornea free of any pathogens, and help to protect it. The cornea is the first barrier, if you will, to the eye. And if the cornea is not healthy and is not clear, that means that we will have problems throughout the rest of the eye. If the cornea is not clear, then we're not going to have as good a vision, and it can lead to other health concerns as well. So what causes KCS? And there are a lot of things that can cause this. These are the most common ones that we see. So drug-induced, surgical, infectious, congenital, and neurogenic. So for drug-induced, if a dog is receiving a sulfa-based oral medication, this can sometimes cause KCS, and this is seen quite a bit. Surgical, we don't see that as often anymore with a little bit of education, but if the cherry eye, for instance, is removed, that is actually one of our two lacrimal glands. And obviously, if we're removing that, then we are not producing enough tears. Infectious, so obviously canine distemper and feline herpes virus are the two big ones there. Congenital, as I mentioned before, there are certain breeds that are very prone to this. Pug, the Yorkshire Terrier, Shih Tzus, Cocker Spaniels. I could keep going, but that's a few of the top ones. And then neurogenic. So if there's any compromise of the CN5 and CN7, that can also cause KCS to occur. So how do we see KCS? What does this cause? Often these dogs are presented squinting. They will have a lot of tearing or discharge, and that discharge can be very thick and mucoid if it's quite pronounced. The patient will be, very irritated because of all that mucus that's now adhered to their conjunctiva and to their fur. So they'll be rubbing a lot. The corneal surface itself will be dry and dull looking. They'll have an increased risk of eye infections because the tears help to reduce pathogens. So they're helping to wash away anything that could be detrimental to the cornea. But if they don't have enough tears, then those pathogens will stay there. They can also have crusty nostrils, and that's because everything's connected. We have the nasolacrimal duct. So often the same side of the nostril will be dry and crusty and can have discharge as well. The cornea can become inflamed, so we can have keratitis, and we can see cornea abrasions and ulceration as a result. So how do we diagnose KCS? So I mentioned this a little bit earlier. For years, it's been the Schirmer tear test, which is very standard. It's a fairly simple thing to do. We basically take these little strips and we insert them under the inferior eyelid, and we leave it there for 60 seconds and then measure in millimeters the amount of moisture that has wicked up the strip. Sometimes this is easier said than done. A lot of patients don't necessarily enjoy having this little paper strip stuck underneath their eyelid. Cats can especially be a little bit difficult to do this with. And with our little brachycephalic friends where they have very prominent eyes, sometimes it can be a little bit difficult for that strip to actually stay there for the full minute. So what else? What other options do we have? So there is the eye tear test. So this is new, and there's been quite a bit of research, not only in the dogs, but in the human side of things as well. And so how this works is it is held in the medial corner at the conjunctival sac, and it's measured after 5 seconds. And these strips are double-ended, so you do one side for the right eye and then the other side for the left eye. And the results do compare quite nicely to the Schirmer tear test. So this is a very nice option for our very wiggly friends or our cats that just don't want to sit still for that to happen. So what happens if we don't treat KCS? So if the cornea is left to become dry, we can get chronic keratitis, we can get corneal pigment, we can get ulcerations and abrasions on the surface of the cornea, and these can become very, very deep, unfortunately. So as I said earlier, you know, the tears help to keep pathogens off of the cornea. There's a normal flora that lives there. However, they're kept in check. And then if we don't have enough tears to wash them away, all of those bacteria can then start multiplying, and then they can start eating into the cornea. So we can end up getting our melting corneal ulcers, we can get dysmetaseals, we can get corneal perforations, none of which are good. The pigment, the corneal pigmentation that can come because those cells are no longer hydrated, that can actually lead to blindness if it is allowed to progress to that point. So then you just have this film of pigment that's covering the cornea, and vision is very much reduced at that point. So how do we treat KCS? What are we doing here? So there's a few different parts to this. One, we want to support the eye, and then we also need to try to stimulate more tear production to happen. And so we try medically, obviously, and if medications don't work, there's a few surgical options as well to treat KCS, which we're not going to get into today, because that's a whole other talk. But what we want to do is to lubricate the cornea with something like the eye drop gel. So that has hyaluronic acid and glycerin. And so that's going to help protect the lipid layer. And then we need to stimulate tear production. So how are we doing that? So we're typically starting with something like cyclosporin or Optimune. And that's because the majority of KCSs that we see are usually an immune issue. So we're trying to suppress the immune system to allow the lacrimal glands to produce tears. So if we do get corneal ulcers, how are we going to treat them? So there's a variety of different methods for treating corneal ulcers, and it does depend on what type of ulcer we have. So is this a superficial abrasion? Is this an indolent ulcer? Do we have melting? Do we have a dysmetaseal? Those will all factor into how we're going to treat the ulcer. So one of the ways that we can treat ulcers, especially indolent ulcers where we're needing to do the grid keratotomy or using a diamond burr, is to place a corneal shield. So what would happen is you're still treating the eye, you'll do your grid keratotomy, and then we would place one of these corneal shields on the cornea, and this is going to help to protect the cornea. It does dissolve on its own, it's just one size, and it is still permeable to medication, so you can still be applying your topical antibiotics, your topical lubricants, topical pain medications if you're giving those. The nice thing about them, they dissolve on their own, so you don't have to have the pet come back in to have it removed. Okay, so we're going to get into cataracts now. So what is a cataract? It is an opacity of the lens. So the light that would normally pass through the cornea, pass through the lens to be focused on the retina, it kind of stops at the lens now. It can't pass through the lens to get to the retina. If the light doesn't get to the retina cannot pass that signal up the optic nerve to the brain, which means the pet can't see anymore. So there's different classifications of cataracts. So we can have an incipient, an immature, mature, hypermature. Usually when we start getting to the immature phase, that's when we're starting to see some vision loss. So as I mentioned earlier, there's a lot of different things that can cause cataracts. There's a genetic component. We can see nutritional cataracts in puppies. If they're not getting their mother's milk, they'll often have a nutritional cataract. We can have traumas. So porcupine quill, I've seen that. Even just, blunt trauma if they get hit with a ball. Endocrine, so obviously our diabetes mellitus, and then age as well. So what are the steps to cataract surgery? We're going to not go super into depth, but we will highlight each step. So starting with our incision and then moving through to when we close with our suture, and we'll kind of go through each of those. So we make an incision, and this is made into the cornea at the limbus. Now there's different sizes that you'll see. It's typically done with a keratome or a crystal blade, and they come in different sizes, and that's because you don't want the incision to be too large. You basically want just enough room for your phaco emulsification handpiece to fit in there, so that you're not having too much fluid seep out around it. So typical sizes range from 2.75 millimeters to 3.2 millimeters. And also the larger the incision, the more time it will take to close. In humans, they often do not suture the incision closed. However, most veterinary ophthalmologists will place some sutures just because our patients don't always listen when we tell them that they need to sit quietly. So a lot of the times we are closing those incision lines. Now, obviously, we're going to be using absorbable suture because we don't want to have to sedate or anesthetize our patients to remove them. So typically, it's somewhere between 7.0 to 9.0 absorbable material that is used. So once we have our incision made into the eye, obviously the aqueous humor is now going to leak out. But when that happens, our eye basically now resembles a shriveled up raisin. So the cornea is not that nice, smooth, clear surface. It's very difficult to view inside of the eye at this point. So what we're going to do is inject some viscoelastic inside the eye, and what that will do is take up space in the anterior chamber, which will allow the ophthalmologist to visualize everything, and it also will help to protect the endothelial layer of the cornea from any damage that can be occurred. So there are many different types of viscoelastic out there, and they have different properties, and so each ophthalmologist will have their own preference, and in some cases it is case dependent about which one that they will use. So we have cohesive, we have dispersive, there's super cohesive, and then you have different combinations of them. And basically what we're looking for is for them to help protect the endothelial layer of the cornea, because if we don't, that can cause corneal edema, which means that the ophthalmologist is not able to visualize through as well. But also the viscoelastic needs to be removed at the end of the surgery, because if we leave it in there, it could cause problems such as glaucoma if it is getting adhered in the drainage angle and not leaving the eye. So there's a bit of a list there of the different options that are available. And again, it's often a case dependent and ophthalmologist dependent option as far as which ones they'll use. So the next step is to often inject a substance like monoblue. And so what this does is it's injected into the anterior chamber, and it's allowed to sit in there for 1 minute. And what it will do is it will stain the anterior lens capsule. So in order for the ophthalmologist to perform cataract surgery, we need to actually get through the lens capsule itself. And so to do that, they have to perform a capsulorrhexis. But sometimes it can be difficult to view that. So by staining it with the monoblue, we're now highlighting the actual anterior lens capsule, which makes it much easier for the ophthalmologist to perform this. So once that's sat for a minute, then we use the fluidics of the phaco emulsification machine to vacuum the rest of it out of the anterior chamber. A little bit more viscoelastic is usually injected, and then the ophthalmologist will perform the capsulorrhexis to enter into the lens capsule. At that point, then we go in with our phaco emulsification handpiece, and basically what happens, it's like a little jackhammer, and it breaks up all of that opaque lens material and vacuums it out at the same time. And then there's that. Once it has all been vacuumed out, then we will go in with an irrigation aspiration handpiece to polish the inside of the lens capsule to make sure we're not missing any cells. So assuming that we are placing an intraocular lens, and I would say that for our practice here, we probably place one 85 to 90% of the time. The only reason that we would not place one is if we do have a posterior lens capsule rupture, or if we're concerned that the lens is not super stable in there. But when we place the intraocular lens or the IOL, we're basically providing the patient with the same magnification and focusing power that they would have had prior to developing the cataract. And again, there's multiple different options that are available. They can be preloaded or not. So they have to be folded up to be injected inside of the eye. So obviously, remember, we have a very tiny incision. It's only 2.75 to 3.2 millimeters wide. So the lens itself is folded up into a little injector, and that injector is inserted inside the lens, and then the lens is injected inside. At that point, it will unfold itself, but then the ophthalmologist usually needs to kind of help it get into its proper position. And so they all have some similar characteristics. They have a central round part with haptics that come off at the ends. And those haptics are basically designed to keep the lens in position, the IOL in position inside the lens capsule so that it's not moving around. And so iMed has a few different options, and the eye lens with the HSM, so this is basically coated with heparin. And what this does is it helps to reduce the amount of inflammation. So certain dogs may benefit from this, especially if they've had a lot of lens-induced uveitis prior to surgery. This will help to reduce the amount of inflammation postoperatively. The PMMA IOLs, or PIMA as some people like to call them, these are one of the first IOLs that were developed, and obviously humans first and then animals. And these you can actually fix them in place with the haptics and their design. Even though they were one of the first ones, they're still used quite often. And again, the lenses are often decided on a case by case. So patients that are requiring a little bit more stability, they may use these as opposed to one of the other ones. So at this point, we've got our intraocular lens in position. We're going to now remove all of the viscoelastic from inside of the eye. So that is done with the irrigation aspiration handpiece. And this can sometimes be a little bit tricky because you can't always see the viscoelastic well, depending on which one you're using. Some are a little bit more visual than others, but you want to make sure that you remove all of that. And then based on ophthalmologist preference and the size of the incision, it would be then closed. And so, as I mentioned before, we're using very small suture here. Typically, it would be an 8.0 or a 9.0 absorbable material. The 9.0 is often a monofilament. So a lot of ophthalmologists do like the monofilament option because it can help to prevent postoperative infection. So we're looking basically for something that is not going to break down prematurely, not cause a lot of a suture reaction to the area, and also not come apart on us. So we mentioned earlier that we want to make sure that we're not, or that we have KCS well under control before heading into cataract surgery. And what is the big deal about that? Well, if our patients have dry eye that's not well controlled, that will delay healing of the cataract surgery postoperatively. And sometimes we can actually induce dry eye following cataract surgery. And how do we do that? When we make our incision in the cornea, obviously we are cutting through all of the layers of the cornea, which means that we are in fact damaging some of the nerves that are there. So those nerves are going to play a role in KCS. So sometimes it's just a minor drop in tear production that we see that may just come back up on its own with the aid of a lubricant. But other times we do end up needing to treat that patient for KCS with a lacrimal mimetic, such as optimium. So obviously we want to try our best to prevent that from happening, which is why it's very important postoperatively to be treating them with a lubricant that helps to keep the cornea healthy. We see this a lot in diabetic dogs as well. Even if we don't do cataract surgery, diabetic patients are more at risk to developing KCS, but because they do have diabetes, they are more at risk for developing KCS postoperatively. And there was a study about that. So again, we want to make sure that we're treating these guys with lubricants. And so often for the first 24 hours, we're usually treating our patients with a lubricant every 2 to 4 hours postoperatively, just to make sure that we are not having that cornea dry out on us. So that is the end of the lecture. I hope that this was helpful for you and that you learned anything. And if you have any questions at all, please feel free to contact iMed Pharma.
Thank you, Katie, for teaching us about cataracts and treatment and postoperative complications. For all the listeners, if you want to get the RACE certification, it would be under the form and resources underneath the webinar. Big thank you to you, Katie. We were very happy to have you on.
Thank you very much. It was a pleasure.
Thank you.